This is going to be a very short voiceover of the assessment of the respiratory system. Again, just make sure that you review some of your anatomy and physiology of the respiratory system if you feel like you need a little bit of a brush up. Some key landmarks, obviously anteriorly, you're going to be focusing on the clavicle, posterior, the scapula, and really just so you're aware when you're listening to lung sounds or you're percussing that you're making sure that you're aware. Obviously, you're not going to hear anything through these sites. And when you're percussing, it's going to be a very flat sound because it's a bone. The sternum, we know, is our breastbone. The top part of the sternum, our manubrium. And then right up at the very top of the manubrium, there's like a little bit of a notch. And that's called the suprasternal notch. So I think everybody can kind of feel that on themselves. And we know the bottom of the sternum or our breastbone is that xiphoid process that kind of hangs down there. And that's definitely an important component to remember when you're doing CPR on somebody. We know we don't want to knock that off, lacerate somebody's liver. The costal angle is definitely an important landmark to know because we have to know that those angles between the costal margins or the end of those bottom ribs, when they make a V and attach to that xiphoid process, the angles are going to be about 90 degrees or less. So if the degrees are greater than 90 degrees, we sense a patient has probably an overinflated lungs, somebody who has emphysema, COPD, so a chronic pulmonary condition. So the angle needs to be less than 90 degrees. If it's greater, we suspect enlargement of the lungs from overinflation of gases. And then obviously our intercostal spaces, those are going to be really important landmarks because that's where you're going to be listening. That's where you're going to be percussing. Okay? Because if you're not going to be hearing things. One of the other important landmarks, it's not listed here, but the sternal angle. And so you can find that between the articulation of the manubrium and the sternum. So right here is going to be the sternal angle. And this is really important because you're going to be locating this initially to find that second rib, because you know that right below the second rib is going to be that second intercostal space. And that's where you're going to start to be identifying where the intercostals are for you to know actually where you are putting your stethoscope and then where you're percussing. Obviously, seasoned, more experienced nurses, we don't spend our time locating the intercostal spaces when we're listening, but I think it's a good starting point for you when you're trying to identify where you're supposed to put your stethoscope. Obviously, if you put it on the chest, you're not hearing much, and this is somebody who's healthy, young, and they're doing everything they're supposed to be for you to auscultate correctly. Chances are you're not in the intercostals, and I would reapply the stethoscope someplace else. Obviously, just the lobes of the lung. We know on the left side we've only got two lobes, the upper and the lower, because we've got our heart. And then on the right side, we've got the right upper, right middle, and the right lower. This is just a cross-section and then another image for you to review the internal structures of the lungs. Make sure you're a little familiar with the linings of the lung and within the cavity, so the parietal pleura and the visceral pleura. So knowing the purpose of them, right? So some of them together are going to make our pleural cavity, pleural lining, which has a little bit of lubrication in it. So that way when our lungs, when we breathe in, breathe out, we know we've got the ease of breathing, that the linings are sliding over each other very easily. Okay? So without it, there'd be a lot of friction, there'd be a lot of irritation. So make sure you're familiar with the parietal and visceral pleura. Another little image here, that's a subset, is of our smaller bronchioles and the alveoli, alveolus. And then obviously our internal, the trachea, the right and left bronchi. Our reference lines, this is definitely going to be important too when we start talking about cardiac next week. Our midclavicular line is going to be important, especially on the left side when we start finding our landmarks for the bottom portion of our heart. But obviously you've got your axillary line down here as well. Those are all very important landmarks to know from this point on, so that when we first say, okay, where's the midclavicular line, where's the mid-axillary line? So some of our subjective assessment: cough. Is it productive? Is it non, if these patients come in with a respiratory component? If it is productive, what does it look like? Is it clear? Is it thick, tenacious? Is it rusty, kind of red colored, So that's pretty ominous. Usually we worry about a pulmonary embolus, or do they have interstitial lung disease? Shortness of breath. Is it shortness of breath at rest? Is it shortness of breath with exertion, activity? Is that new, or is it a chronic condition? Sudden, or is it gradual in onset? And then chest pain. And we know with all of this subjective information, we're doing a PQRSTU. Okay. So chest pain. Sometimes when we think of somebody with chest pain that's associated with pulmonary condition, usually it's going to be sharp. It's going to be worse with coughing. It could be worse with taking in a deep breath. What happened first? Did the patient have cough and shortness of breath and then chest pain? What's the correlation to each other? They have a history of respiratory infections. Frequent pneumonias often make you think of an underlying lung pathology. Or do they have some sort of genetic predisposition to something that we don't know about? So that's a definite thing that we should be asking about. Sometimes our patients who have COPD and chronic lung conditions, when they're constantly in and out of the doctor's office or the hospital with recurrent infections, sometimes it lets us know, okay, the disease might be getting worse, and then they also might not be very compliant, taking their medications, living the healthy lifestyle that they should be. Obviously, history of lung disease, and that can encompass a lot of things. Like I mention a lot: COPD, emphysema, chronic bronchitis, asthma. Some patients who have been coal miners, been exposed to asbestos. So those patients might have more of a interstitial lung disease related to their work environment. And then obviously smoking, firsthand, secondhand. How long? If they smoked, how many packs a day, and how long as far as years? And we just mentioned not only environmental exposures, so not only work conditions, but what region of the country do they live in? Is it a heavily small populated area? And then self-care behaviors. So I can think of like influenza. Do they get a yearly influenza vaccine? Are they older than 65 or immunocompromised and they need an pneumococcal vaccine? So objective assessment, obviously, again, the first thing we're going to do is inspection. So the color of their skin, and we're looking at their mucous membranes and nails. More commonly, probably if this is respiratory, we're looking for cyanosis, right? We most commonly are going to see it in the nails, maybe the oral mucosa first, and usually if it goes more central to their trunk, it's pretty severe. And cyanosis, don't forget, is a very late sign of hypoxia. It usually means, obviously now, it's hypoxemia. It's pretty severe in the blood. Pallor, that might be another issue to consider. Presence of clubbing. We know clubbing is when we look at the nail bed and the angle is greater than 180 degrees. The nail bed's also going to be pretty spongy. Clubbing is also associated with chronic hypoxia, people who have chronic long-term pulmonary disease. Posture, are they erect, upright? And then we're also going to continue to look at their respiratory rate, rhythm, depth. Is it deep? Is it shallow? And then obviously effort. When we think of effort, we think of work of breathing, the ease of breathing. And so a lot of times patients aren't using a whole lot of other accessory muscles to breathe. But if a patient comes in, they're breathing 30 times a minute, they've got some bluish discolored nails, their nostrils are flaring because they're air hungry, they're oxygen hungry, or they're using their neck muscles, they're using their sternocleidomastoid. You can see a lot of their intercostals retracting because they are working so hard, they're exerting so much energy to take in oxygen. And those patients, typically when they're using that much energy to actually breathe. They're going to wear out very quickly, and it's going to turn into a emergency situation. Level of consciousness. Usually the first indications to a nurse that a patient has hypoxia is if patients start to become a little irritable, restless, maybe even a little confused. When the hypoxia gets to the point of where it's hypoxemia and it starts to drop, a lot of these patients will then start to have depressed level of consciousness, coma. So there's various ranges. So when we're looking at these patients, level of consciousness, are they irritable, confused? Is their memory off? Are they actually lethargic and difficult to wake up? Signs and symptoms of respiratory distress. And we talked about the costal angle. It should be less than 90 degrees. And so usually if it's greater, we think of overinflated lungs. So that kind of leads us into chest shape, configuration, the diameter of the chest. So this middle picture here is a very appropriate looking chest diameter and chest shape and configuration. Obviously, if we're thinking of people who have skeletal deformities such as scoliosis or kyphosis, which is that humpback that some of the older patients who have osteoporosis, some of them are severe enough that they can actually change the chest configuration and diameter of the chest and make it difficult for these patients to breathe in adequately and exhale adequately. An important component to know, if the patient doesn't have a normal diameter of the chest, a normal diameter of the chest should be a 1 to 2, which means if you look at the patient from sideways and then you compare it to the transverse, the sideway view should always be half of the transverse, okay? So it's the AP to the transverse ratio should always be 1 to 2. So looking at them from the side should always be half of looking at them from the front or back. If it's a 2 to 2, like if it's a 1 to 1, and that's considered kind of a barrel chest. So if you're looking at these patients from the front and then at the side, and if it looks about the same, these patients have increased AP diameter, they've got a barrel chest. And we again think of patients with emphysema, COPD, and it's associated with overinflated, hyperinflated lungs. So eventually, over time, these patients who have a difficult time breathing out, exhaling CO2, they've got restricted limitations, and that they have all of this air that they can't effectively get out. It's going to overinflate their lungs, and their chest cavity is actually going to change in size and diameter. The barrel chest. So palpation. So obviously we're going to palpate the trachea for the position. We can go up to the suprasternal notch with our thumbs, and we can go up and kind of palpate the trachea. We want it to be midline. We do not want to shift to the right or left. That's an emergency situation, right? We could have a pneumothorax, a hemothorax, a complete collapse from a pleural effusion. And so when the trachea shifts, it's usually because the one side of the lung that's become so collapsed onto each other starts to push into the medial sternal area, the whole middle section of the lungs and the heart, and actually pushes it over. And so we're going to see a shift in the trachea. So we're going to palpate the anterior and posterior. We're looking at the chest wall, some of the bony structures. We know the spinous process on the back. The C7 usually is where we're going to start when we're palpating the bony structures from the back. So we're looking at the symmetry of the spine. We're also looking at the skin texture and temperature. When we're looking at the anterior and posterior, again, we're always looking at symmetry from right to left. We're assessing for any types of tenderness, lumps, or masses. And then we're palpating for thoracic expansion. So we can do that posterior, we can do that anterior. And so we're going to place the tips of our thumbs together, and we're going to ask the patient to take in a deep breath. And so our thumbs should move equally with expansion. If there's unequal expansion, we usually think of, atelectasis, pneumonia, pleural effusions. Some other things we can look for is crepitus. Some of your patients who actually have a collapsed lung, And if they can have air that escapes from actually outside of the lung and it accumulates under the tissues, under the subcutaneous tissues, it can actually cause a bubbling up under the skin. And if we palpate it, it actually feels kind of like Rice Krispies. And we refer to it as crepitus. Another medical term is like subcutaneous emphysema. So if you actually take your hands or fingers and kind of palpate along the areas where they have this accumulation of air under the tissue, it's going to kind of sound like Rice Krispies. Another thing that we can do is palpate for vocal or tactile fremitus. A little bit of palpable vibrations is normal, as long as it's equal from side to side. And again, if we're assessing for tactile fremitus, we're using the ulnar side of our hand, or we can use the base of our fingers. But we typically are going to start at the top. We're going to work our way down, side to side. And we're going to ask the patient to say 99. And so sometimes if there's increased fremitus from one side to the other or decreased, there may be poor air movement. If there is a collapsed lung or widespread atelectasis, or if there's consolidation, pneumonia, congealed infected material in the lung lobe base, we might have increased tactile fremitus. So percussion, we know when we're percussing over the lung fields where there's air, it should have that resonant sound. Unless the patient has COPD or overinflated lungs, then it would be hyperresonant. But resonance is what you should be hearing over the lung fields, not over the ribs or the scapula. That's going to elicit a flat sound, right? Like tapping a book. Dull would be more over the liver or heart, which is what we would expect. But we need to make sure when you're percussing, you're doing it over the intercostals, actually over the lung fields. Okay? So you're going to be doing it in the same manner or the same pattern that you're going to be auscultating. And when you're doing it, again, obviously you're noting the tone, the pitch, and the duration. And you're going to start at the top, move your way side to side and down to the bottom, because we're always comparing side to side. And again, this is an acquired technique, and it's more for an advanced practice, but you are going to practice it in lab this week. So you're going to be doing it anterior and posterior. And obviously doing it posterior on somebody is going to be a lot easier. You're going to ask them to sit up and bend their head forward. And you know, you're doing it, it's kind of all in the wrist, again, just an acquired technique. You're going to be using the middle finger of your non-dominant hand, and that's the stabilizing hand. And then you're going to be using the middle finger of your dominant hand to flick right over the nail bed. 2 quick successions. You got to get in there and practice. Okay, so auscultation. So we're going to be doing it on the same points that we're doing it for percussion. And make sure as you're preparing for your health proficiency exam that you remember that Professor Needham, there's 5 points to auscultate on the front, 2 on each side or lateral, and then 7 on the back. Okay, and she'll talk about that with you in lab on Friday. But 7 points on the back, posterior, 2 on either side, lateral, and 5 on the front, anterior. You're always using the diaphragm portion of the stethoscope. Make sure it's warm. You're not to be using it over a gown or over clothes. Make sure the room is quiet, that you're not talking, the patient's not talking. Make sure when you do it that you're auscultating in the same system that you're doing as percussion, side to side, top to bottom. Make sure you're in the intercostals, that you're not over the clavicle, over the scapula, or the ribs. In order to get an adequate sound, because you guys are going to be listening to each other and everybody is healthy, make sure the patient breathes in and out deeply and slowly through the mouth. That's the best way to hear, to auscultate. Make sure your patient does not hyperventilate. I think the video, if you watch it this week, it's going to tell you with older patients, kind of start at the bottom, at their bases, so that way they don't get worn out. Because sometimes you're going to see when patients in the hospital do have adventitious lung sounds, they're going to be at the bases. Okay. So yeah, normal, start at top to bottom, left to right, but in some of your older patients, you might start a little bit lower. You want to make sure that you leave the stethoscope in place long enough to hear the complete respiratory cycle. One inspiration followed by the expiration. Okay? You're not in a hurry. We talked about side-to-side comparison. And again, not over chest hair, not over the gown. All right, so this is kind of the sequence from the front, like we said. 5, on the back 7, and on each side here you've got 2. That's going to be your pattern for your health proficiency exam. So this is going to be a skill that you're going to have to take your stethoscope home and you're going to have to practice. All right, so what are normal lung sounds? This is one of the most important skills that you can acquire this semester. You've got 3 types of normal sounds. So you've got the bronchial breath sounds. That's going to be up over the tracheal area, okay? When you listen to it, it's going to be an easy sound to hear because it's going to sound just like a tube, hollow. It's going to be greater on expiration than inspiration. Okay. The other sound that's going to be more over the right and the left bronchi is going to be bronchovesicular. Okay? On inspiration and expiration, it's going to sound the exact same. And it's going to be a mixture between that tubular hollow sound you just heard and rustling wind. But either way, it should be clear. You're not going to be hearing any type of abnormal sounds. It should be clear. And then the most common sound that you're going to hear, because it's most of your lung fields, is going to be vesicular. And this is going to be your alveoli and your bronchioles. On inspiration, it's always going to be greater than expiration. And this sound is typically going to sound like rustling leaves through trees. The bronchial, bronchovesicular, and vesicular breath sounds. I know in lab on Friday you're going to listen to kind of the simulation man to kind of listen to normal lung sounds. Again, like we said, bronchial, over the tracheal area, hollow tubule. Bronchovesicular, a combination of tubular, rustling winds in the trees. And then, like we said, most of your components are going to be vesicular. All right, so abnormal sounds, again, important. So wheezes. So wheezes is like air movement over narrowed passages, and it typically is going to sound like musical sounds or notes. Very characteristic. You're going to hear it in a lot of your patients who come in with asthma, COPD. And the good thing about wheezes is, though, you still have air moving through it. It's just through a narrowed space. So we can hear it on inspiration or expiration. Sometimes it's loud enough that you can hear it without a stethoscope. Bronchi, you're typically going to hear that in the upper airways, more maybe in the bronchovesicular regions, bronchi. It's usually going to be more of a rumbling sound, and I would say it's more associated with phlegm, sputum, and so sometimes if you can cough and get it out, the bronchi does go away. Stridor, upper airway around the laryngeal area. You've got laryngeal edema, somebody who comes in with maybe an allergic reaction, anaphylaxis. I think children can come in with, other upper airway narrowing, stridor. You can actually hear this without the stethoscope as well. Sometimes you can hear it from the door. It's a medical emergency. Remember, airway, breathing, circulation. Crackles, there are 2 types of crackles or rails. You might hear it as fine and coarse. And you're typically going to hear those in the lower bases, the lower areas of the lungs. The finer rails are going to truly sound like Rice Krispies as well. You can hear them on inspiration. When they're coarse, with fine ones, sometimes it can be with atelectasis when the alveoli pop open when you're breathing in. Other times it might be a little bit of pneumonia. If you hear coarse crackles, it's really loud, and usually is related to fluid from heart failure or kidney disease, where the fluid has accumulated in the alveoli. Pleural friction rub is pretty characteristic. You don't hear it a whole lot. But when patients come in and they've got pleurisy or they've actually got a pleural effusion, where fluid has actually built up within the pleural linings of the lung cavities. When the lungs, you breathe in and out, the linings of the lungs can actually rub together and create this grating sound. And you're going to hear it continuously throughout inspiration and expiration. When you hear adventitious lung sounds, make sure you document what you hear, the type. Did you hear it on inspiration or expiration? And again, that's going to take you a while to acquire. You're going to have to listen over and over. And where did you hear it? Did you hear it at the apices or did you hear it at the bases? If your lung sounds are clear, you can document lung sounds clear to auscultation throughout all fields. So voice sounds, definitely a more advanced skill. And all three of them are going to be assessing for consolidation at various ranges. So bronchography, so you're going to be taking the stethoscope and listening in the same manner that you did just for auscultation, but this time you're going to be asking the patient to say 99 as you go to each point where you're going to listen. It should sound muffled. So if the patient says 99, 99, and you're going over and listening, a normal finding is that it should sound muffled. If it sounds clear, there's lung consolidation within the lungs, so bronchophony. That is abnormal voice sound. Whispered pectoriloquy. So if you actually are listening again in the same points with the stethoscope and you have the patient whisper 1, 2, 3, it should sound like a whisper, but if it sounds loud and clear, again, the patient probably has some lung consolidation, so fluid, an accumulation of congealed fluid is within the lungs. Cacophony, this is another indication for lung consolidation. If you're also listening to those same points and you're asking the patient to say E, E, it should sound muffled. But if it actually sounds like an A instead of an E, the patient also has lung consolidation. So again, it's good to know you're going to practice, but you're definitely not going to be doing this frequently in practice. All right, so some developmental considerations. Some of our older patients, as they get older, their AP ratio does change, just kind of like somebody with COPD. And then they also start to have some costal cartilage changes. They become calcified, which can impact thoracic expansion. And so can affect, patients taking in deep enough breaths or even exhaling everything they need to, so older patients. And then some cultural and genetic considerations. The incidence of tuberculosis, we know there's been a decline over the years. Obviously, good prevention techniques, good treatments. But we know that with a lot of migration, we do see patients that maybe their immune system is not up to par. Maybe their living conditions are not where they need to be. And we also know that it's very difficult to treat patients who have tuberculosis because the treatment for tuberculosis is multiple antibiotics for like 9 to 12 months of the year. So we do see an increased incidence of tuberculosis in immigrants from various different countries. Incidence of asthma, we know that's associated with kids, obviously. Its genetic component also composed of environmental issues as well. And then we kind of talked about chest volume size with the aging, but it also does talk in the book a little bit about that in the Asian population, their chest size is a little bit smaller, so it can affect their vital capacity, what they're actually able to take in, and how much they're able to breathe out. So here's just a slide that takes you to some links for you to practice listening to some lung sounds and auscultation techniques and voice sounds as well, in addition to the clinical essentials videos.